Welcome to the 43rd Helen Nahm Research Lecture. A warm welcome to the awardee, Dr. Linda Franck, to the Associate Dean Alcon, to the Associate Dean Alcon, and to all of you. I'm Elena Portacolone. I'm an associate professor in the UCSF Institute for Health and Aging, and I'm the chairperson of the SON Research Committee for 2023-2024. And a warm thank you to this year committee members, Abby Alcon, Yoshimi Fukuoka, Soo-Jong Lee, Sandy Stavesky, Maria Yefimova, and Lili Xu for steering the Helen Nahm Selection Committee. On behalf of the Research Committee, I would like to thank you all for joining us today to extend our heartfelt congratulations to Dr. Linda Franck for her achievements in nursing research, education, advocacy, leadership, friendship, mentorship, and much, much, much more. And Dr. Franck is an inspiration to all of us, and it fills us with the greatest pride for her continued contributions to nursing education and research. Fittingly this week, we are celebrating the Nurses' Week, a time to honor the invaluable contributions of our nursing colleagues. I also would like to celebrate the openness of our nursing colleagues to collaborate and support the UCSF community and much broader. For example, I would like to celebrate our colleague Karen Barrett. Can you please stand up? Yeah. Karen was recently awarded the School of Nursing Intramural Grant to test a music therapy intervention for Chinese Americans with dementia here in the Bay Area. Now, I would like to introduce you to wonderful Dr. Abby Alcon, who is Interim Associate Dean of Research, Barbara Durant Presidential Chair in Nursing, and Director of the California Childcare Health Program.
Thank you, Dr. Portacolone. I'm here today because I'm standing in for our new Dean, Carol Dawson-Rose, who's on an airplane going to Hawaii. So she's not able to be here today. So as the Associate Dean for Office of Research, I'm here to welcome you all. I'm very happy to have us celebrate the research career of our 43rd Helen Nahm lecturer, Dr. Linda Franck. And I'd like to also recognize all of the recipients of the past Helen Nahm Research Lecture Award and ask you to stand up so we can recognize the amazing contributions you've had over the years. Thank you. I'd like to tell you a little bit about Dr. Helen Nahm. Dr. Nahm received her diploma in nursing in 1924 and her doctorate in education psychology in 1946. She pioneered efforts toward accrediting nursing programs when she worked at the National League of Nursing. In 1958, she became the dean of the UCSF School of Nursing. She was a pioneer, and she advocated a model of nursing education that was visionary and daring. She proposed that research and teaching were inseparable and asserted that teaching was a form of inquiry. She created the first nursing doctoral program on the West Coast, and she also established our Social and Behavioral Sciences Department, which was the first basic science department within any school of nursing. She brought a group of sociologists to teach our students how to conduct rigorous qualitative research using grounded theory. She served as our dean for 11 years. According to Dean Nahm, quote, "The primary function of graduate programs is to prepare nurses for leadership positions in nursing education and nursing service and for research." This is part of her legacy that we celebrate with this research lecture today. In tribute to this extraordinary, far-sighted nursing leader, we are here today to celebrate by honoring another scholar who has done a lot to maintain the spirit of Dr. Helen Nahm. We have Dr. Linda Franck. And now I'd like to introduce Dr. Susan Cools, who is going to introduce Dr. Franck. And Susan Cools is a Madge Jones Professor Emeritus of the University of Virginia and Professor Emeritus of UCSF School of Nursing. Thank you, Susan.
Well, it's wonderful to be here to see you all. I want to wish you all a very good afternoon and welcome. And thank you for coming today. It's so nice to see some familiar faces and also to see many new faces of our doctoral students and postdocs here today. I want to thank you again for coming, but want to especially give a little welcome from a distance to Linda's family, who many of them will be watching this either from a distance or a bit later on the video. There have been a lot of healthcare encounters that are competing with today, but I also see there's a member of her family that's representing the crew, so welcome to you all. I also wanted to just do a quick acknowledgement of another Helen Nahm recipient, Adele Clark, and we will be honoring Adele at the end of the month in May at her memorial, and she is really missed, I'm sure. Okay. I'm honored to be here to introduce our speaker. Today you're going to hear about the arc of the considerable legacy of Dr. Linda S. Franck as she presents the 43rd Helen Nahm Research Lecture, one of the most prestigious awards given by faculty colleagues to honor a UCSF graduate, or actually a UCSF alumnus. So here we are. To introduce Dr. Franck in a way that's appropriate to this laudable occasion, I asked myself, where did Linda's research curiosity and pursuit of knowledge begin? And I spoke with Linda's younger sister, Terry Rousseau, who couldn't be here today. But I asked her, what were the early signs that your sister was going to be a great scholar? In other words, a complete research nerd. Terry talked about her sister with immense pride. Linda's the eldest child of Mother Barbara and Father Rigo Sturla. The seeds of Linda's leadership were planted with her younger siblings, who you see here, Jim, John, and Terry, where Linda was often the ringleader. She was always interested in science and problem solving, sometimes to the chagrin of her siblings. Like many eldest children in the birth order, Terry remarked that being big sister was basically training for world domination. At least in the Sturla family. Linda's early drive became centered on the question, how can we relieve human suffering? And later, this became refined to ask, how can we eliminate health inequities that undergird human suffering, including those fostered by the healthcare system itself? Both professionally as a nursing director in neonatal and pediatric intensive care settings, and on-call nurse to countless family members with her time, talent, and consultation. She was always generous in service to others. She developed a deep love of caring for infants and children and their families, advocating for parents' presence at the bedside and the critical role that they play in the healing of their child. And here's Linda taking care of her niece Jessica with her sister Terry in the NICU. And Jessica is now 26 years old and doing very well. We hope to see her later today. Now, I've known Linda for many years, and I've seen her in action. We have different colored hair there, you probably noticed. It's been a little while. In fact, we were hired into the Department of Family Healthcare Nursing from the same search in the mid-1990s. Thank you, Dr. Sandra Weiss, who was the chair of that committee all those years ago. Linda seemed so much smarter and together than me in our new assistant professor roles. I had my first big research presentation coming up, and when I mentioned it to Linda, she said, "Oh, don't worry. Come on down to my office and I'll give you some tips." Eager for her advice and consultation, I sat down next to her desk with my notepad in my hand, really ready to get the pearls of wisdom. She fired up her computer and she said, "Okay, Susan, first, what are you planning to wear?" And I said, "What?" And she said, "What are you planning to wear? This is really important. It's all about how you present yourself. You have to have your outfit match your PowerPoint slides." And Linda lived up to this reputation. Not only has she received many awards and honors for her research excellence, she could have given Dr. Afaf Molis a run for her money on the best dressed speaker at the podium. Very early in our career together, Linda Christine Kennedy and I were invited to give the keynote speeches at the first annual Pediatric Nursing Conference in Hong Kong, representing experts in care across the stages of childhood. Now, it was much too early in our careers for such a high honor. I certainly felt like an imposter. But Linda set the stage, kicking off the talks with such poise and professional presence and expertise that the rest of us fell into place, and it was really well received. We went on to receive funding from the UC Pacific Rim Research Program to study the experiences of hospitalized children and their families in Hong Kong and China. And when we traveled back to Hong Kong to plan the study's implementation, I was Linda's roommate. Much to my surprise, the night before a big meeting with the pediatricians at the Queen Elizabeth Hospital, Linda got a phone call. It was about 10:30 at night, and she put her hand over the phone, and I was already in bed. She turned to me and said, "Susan, would you mind leaving the room for a little while? I've got to take this phone call, and it's really pretty private." "Sure," I said, and I spent the next hour, you see me here, in the lobby of the hotel. Linda had apparently just begun a torrid international romance with this stranger from London, and she was trying to keep it secret. And I guess the embarrassment of sitting in my pajamas in that lobby was worth it, because right there in the third row sits that stranger, her dear husband, Bill Sherlock. And my friend Bill deserves a bit of this award, as he's supported Linda every step of the way in her career. It's not easy being the partner of such an internationally renowned researcher, writing grants and papers through just about every holiday. You know the drill. Being unavailable for both everyday and milestone events. Through it all, Bill has been by Linda's side, keeping her grounded as he swept her up in his plane, taking her on travels to forget her work, even for a brief respite. Seriously, I hope I've humanized the formidable researcher that Dr. Franck is. Her considerable contributions to science began with formative work in understanding the experience of infant and child pain in the context of intensive care. This was at a time when infants in particular were severely under-medicated, especially during painful procedures. She centered the family in the care of sick babies and children, elevating their presence and voice at a time when they were often restricted from the bedside. She brought parents to the table to actively participate in advisory boards to research teams at a time before participatory research was seen as a best practice. Dr. Franck has led and collaborated in many important global initiatives to improve care experiences and outcomes for children and their families, establishing the Ronald McDonald House Research Center, which is housed in the School of Nursing, and co-leading the UCSF Preterm Birth Initiative, which is to improve outcomes of prematurity both locally and in low-income countries around the world. All of her work is influenced by the moral imperatives for social justice and health equity, none more so than her co-leadership with Dr. Monica McLemore in Actions, the abortion care training incubator for outstanding nurse scholars. Actions provides funding, training, and mentorship for scholars of color to promote reproductive justice through their research. In addition, she's been the leader of Rejoice, Racial Justice in Neonatal Intensive Care, a group that is operationalizing how systematic racism underpins and impacts infants of color and their families. With over 280 peer-reviewed publications, that kind of takes my breath away, Dr. Franck has rightfully received many honors. She's a fellow in the American Academy of Nursing, as well as one of the very few nurses received as a fellow in the American Pediatric Society, giving nurses a seat at the table of this very important healthcare organization. In addition to her endowed chair in pediatrics at UCSF, Linda's been appointed to several honorary professorships, including Great Ormond Street Hospital for Children and King's College in London, the University of Sheffield in Yorkshire, Queen's University in Belfast, and the University of Toronto. I could go on, but interestingly, when I asked Linda what she's most proud of from all of these accolades, she named 3 things. First, the 2013 publication, which you see here for parents, entitled Comforting Your Baby in Intensive Care. Over a decade later, she still gets 10 requests a month, and it's been translated into 7 languages, providing countless parents and caregivers with help. The second is the WAT-1, the Withdrawal Assessment Tool. Developed in 2007 with colleague Dr. Martha Curley from Boston Children's Hospital, WAT-1 is available in 27 languages and continues to provide critical guidance in the assessment of opioid and benzodiazepine withdrawal in infants and children. Finally, mobilized in 2016 and continuing to meet monthly, close to a decade later, she facilitates the Parent Panel, an advisory and co-researcher group of parents and parent advocacy organizations. Their collaborative work has informed clinical practice and policy and is a true example of authentic community-partnered research. These achievements remind us that not only is Dr. Franck humble, but sometimes our most basic work is actually the most impactful and enduring. Can you think of a more fitting scholar to receive the Helen Nahm Research Award? I can't, and I'm happy to present you my friend and our speaker for today, Dr. Linda S. Franck. We'll do a little computer exchange.
Wow, everybody. You can all go now to the reception. Susan has said it all. That is the amazing Dr. Cools, and she is a brilliant scholar in her own right, a marvelous friend, and I think she showed great restraint in not embarrassing me too much. Those stories she could tell. So let's see if this comes up. Here we go. Great. I need a moment. That was really a lot. So, thank you again, and thank you for all being here, and thank you to everyone online. It's a wonderful opportunity to remind us of this incredible community we have at the School of Nursing, and we're going to make it in this new home just as special as it was in our last home. So in the spirit of gratitude and with so much gratitude to be able to share, please indulge me in a little bit of an Academy Award moment. To me, this is as much of as special as that. I want to thank Dean Dawson Rose, even though she's on the way to Hawaii. And I want to thank all of our former deans for continuing continuing to support the Helen Nahm Award. It's really a very special legacy and deserves to be honored, and we're all the beneficiaries of that here. I want to thank Dr. Portocoloni. I want to thank Dr. Alcon, who's now our Associate Dean, for their wonderful introductions, and the members of the Research Committee for this honor. I know it's a lot of work to do these awards for fellow faculty. It's a lot to wade through on top of all your other jobs, but again, it's so important for us. And I want to thank the people who nominated me. You know who you are, and thank you so much for, again, taking the time, making the effort to put forward my application. This is an incredible honor. And as you heard, Dr. Helen Nahm is a pioneer in nursing science, and her scholarship, as well as all the past recipients, some of them here who you've just seen, really represent the best of UCSF's School of Nursing, and I am just so honored to be considered now among them. But I want to be really clear and upfront with you guys before I make my remarks. This award does not belong just to me. This award belongs to my research teams, to all my staff and administrative support in the school that help make this work happen. It belongs to the parents and participants in the studies and who are also the collaborators in the studies. It belongs to all my amazing clinical colleagues where the questions come from and who do the work and you know, demand that we do better science and help us figure that out, how to do that. It belongs to them. It belongs to all of you, and it also belongs to my family, my husband, Bill, and all my family online, because I couldn't do this work without you. So thank you. I dedicate this talk to all of you. All right. I got through that. And it's, as I think was mentioned, it's not just a happy coincidence, but by design that this is scheduled. This award is always scheduled during Nurses Week because we need to celebrate nurses. And so for those of you who are in the room who are not a nurse, please make a point of thanking a nurse this week. And we're going to make it really easy for you because there's a lot of them in the room. And when we get out to the reception, you can just go thank them and appreciate them for all that they do, 24/7, 365 days a year to support everyone's health. And for those of you who are nurses, take a moment and appreciate what you do for everyone in all the different roles that you have. You have the most important job in the world, whether you're in a hospital, in a clinic, in a classroom, in a boardroom, anywhere. You are the guardians of society's health. And so you need to appreciate what it is that you contribute. So what does it mean if you're a nurse and a scientist? Well, let's take a minute to unpack the terms. According to the Science Council, a scientist gathers data, tests hypotheses, reports their findings. A scientist might specialize in a type of method. They might specialize in a type of question or a topic. They might go into a certain application of the science. But basically, the characteristics that they share are just that they're united by relentless curiosity and the way they systematically do their methods. So what that means is, by this definition, scientists are amoral. Now, he didn't say immoral. I said amoral. And what I mean by that is that their curiosity and their methods could be used for public good, or they could be used for selfish purposes, self-indulgence, or for profit. They can be used any which way. So really, the science, and perhaps even the scientists themselves, is just a tool, right? It can be used for any kind of purpose. In contrast, the nurse scientist, or the nurse midwife scientist, is governed by a social contract, where society bestows certain privileges and authorities to them in return for a commitment to use their education and their skills for the betterment of society's health. Now, nurses agree. Come on, animation. There you go. Nurses, as part of this social contract, nurses agree to practice with compassion and respect for all people. They have a commitment not to organizations or to governments, but their commitment is to their patients, whether they be individuals, communities, or populations. They commit to protecting health and safety of patients, families, and communities that they serve. They collaborate with others in protecting human rights and reducing health disparities. And nurses use research and scholarly inquiry to do all of that, as well as integrating principles of social justice. So you see, this social contract that we agree to for the privilege of being a licensed registered nurse in the US and most other countries is more than just practicing science. Yes, nurses use data, know specialized methods, test hypotheses. They do all of the science that a scientist in another field would do it. do, but they also have a social commitment. And for those of us who are drawn into a career as a nurse scientist, there's a point, a pivotal clinical aha moment where I think we realize that, you know, in order to deliver on our social contract, in order to deliver on our mission to care for and protect the health and safety of patients and communities, that we need the tools of science to do that. And so for me, as Susan alluded to, that pivotal moment happened as a neonatal intensive care nurse, fresh out of nursing school, and discovering that babies weren't given anesthesia or analgesia for major heart surgery. Some of you may have cared for patients in that state as well. And nobody, and even worse, nobody had even researched it to see whether they needed analgesia or anesthesia. And so with mentorship from brilliant UCSF nurse scientists such as Nancy Powers, Lynn Saavedra, and Chris Myskowski, and many others, I began to study infant pain. And then that led to studying children's pain because children's pain was not being properly assessed or treated. And knowledge about pain and how to treat it started to grow. And more people joined the field, and it was a really exciting time to be a nurse scientist. We discovered a lot. And one of the things that we discovered, which was really exciting, was that parents were crucial in adequately preventing and treating pain from the many painful procedures that babies and children are exposed to in hospitals. In fact, we could call parents effective pain medicine. In some instances, the parent-delivered interventions were more effective than the strong opioids, and always with less side effects. But during that time of such excitement about new parent-partnered pain treatments, I was confronted with some uncomfortable truths. First, that our health system is not set up to be patient and family-centered. It is provider and organizational-centered. And even more disheartening, the research enterprise is even more paternalistic and objectifying of people, treating them as research subjects, having no voice in what questions get studied, how they're studied, or how the results will be used. It was very disconcerting, and it made it really hard to do good nursing or to do good nursing science. So fast forward to the decade I spent in the UK, and now you know how I got there. And contrary to popular belief, it wasn't just all castles and tea parties. Although we did have a tea party there's my niece Jessica, and grandchildren Callum and Abby, and niece Natalie visiting us in the UK. I was fortunate enough to be at the UK in a time where there was a collective and concerted effort to bring meaningful patient and public involvement to all corners of the healthcare system. I had the privilege of a front row seat in learning how to really move from token engagement of the public in research to actually really doing it and getting full partnership all the way through the research process and at the stage of research governance. I had formed strong bonds with some incredible young people and caregivers as we worked together to redesign how clinical research was done. And once you experience how truly powerful these partnerships are, you just can't go back to doing research the old way. It just isn't possible. And so fast forward to moving back from the UK to California and to UCSF, I now had the privilege to help bring some of what I learned there to work with folks here. And this is a picture of some of our community advisory members from the California Preterm Birth Initiative. This is standing outside of San Francisco City Hall on World Prematurity Day in 2019. A really special memory. So in my remaining time, what I'd like to do is go a bit deeper with you and share 6 examples of how we've tried to make good on this commitment to research partnership. And I hope you too will be as inspired as I have been and join in the movement as a scientist, as a patient, as a caregiver, as a community partner. I think we all play a role in helping really encourage this movement. So my first example is family integrated care, FICARE, and I see some folks from the ICN here, which is great. Thank you for coming. It's really wonderful. This is a redesign of the care delivery system from a provider-centered focus, as I mentioned, to a more family-partnered model. And when we started this work in the mid-20-teens, we already had tons of evidence that babies survived and survived without disability, more likely to survive without disability if their parents were actively involved in their care. And yet, again, the system didn't really allow it, and parents really had to struggle and fight hard to be actively involved. There were just so many barriers. And we started hearing about this family integrated care model that was being researched and implemented in other countries as something that organized care differently and could really help with that. And so, but yet there was no uptake of it in the US. It just was like crickets. So with some amazing collaborators, clinical collaborators at 3 different hospitals, the 2 UCSF Benioff Children's Hospitals and the Community Regional Medical Center in Fresno, and with parent partners from each of those sites, we set about to see if we could make FICARE work in the US. And even though most of us went into the project thinking we sort of knew what needed to be done and having strong opinions, we took it slow, and we spent a lot of time just meeting together, learning in co-design, having coaches from the tech industry, and just deeply listening to each other and learning what we could do better and really seeing everything through each other's eyes. And that deep work did pay off. And we redesigned a model that we thought, a FICARE that we thought would fit well for the US. It included parents having a speaking role and presenting on rounds, and that just small little shift really changed the team dynamics and made them part of the care team. Organized group classes. This is a picture of parents doing infant massage on baby dolls and having a wonderful time and being able to interact with each other while doing that, taught by an amazing nurse, Deshawn Moore from Children's Oakland. We organized parent mentors, so parents who had walked the walk and wanted to then come and support other parents going through that journey. And then the parents decided that they wanted an app as well. They were tired of paper and pencil. They live in California. They wanted information, and they wanted to be able to connect through technology. So they designed it themselves. It was amazing. And so with that, parents also then helped us design the research, figure out what questions to ask, what were the important things that mattered to them, how best to get the data in a respectful way, and really co-design the whole process. And guess what? The study was a success. We learned that babies had fewer hospital-acquired infections under the FICARE model. We learned that mothers had fewer symptoms of depression and post-traumatic stress, which is critically important for not only their own health, but the health of their family and the child's long-term development. And hospitals started to adopt the program and provide resources for expanding family support and partnership. And the thing I love the best is that parents started showing up on hospital committees and being, part of the governance and the advice of the whole of the operation. And that was really, really exciting to see. And here are some of our parents presenting, again, at another World Prematurity event at a different year. But seeing them share the work, they were listened to much more than I ever was in terms of having impact on clinical practice. So it was great. Try never to do a talk without a community partner with you. You'll have much better success. And so then we had the opportunity to push the boundaries even farther with the work of the California Preterm Birth Initiative. This was funded by Mark and Lynn Benioff, and we had an extremely ambitious goal of trying to address the root causes of prematurity, the epidemic of prematurity in underserved communities in California, and the freedom and the resources to try new approaches. And new approaches were desperately needed because these communities had experienced disrespect, neglect, and actual harm from healthcare, science, and universities, and they were not eager to partner. It took a lot of work. It took a lot of sustained time and effort and demonstrating a true willingness to partner and to share goals and resources and power with the community. But we stuck it out and we worked hard to earn trust. And it also took the redesign of how research priorities get decided and funded. We had to keep working more upstream. Taking some of the methods that I learned in the UK and working with my brilliant collaborator, Dr. Monica McLemore, and community-led organizations, we created what we called the Research Prioritization by Affected Communities. I know, my sister Terry's gonna tell me I need a better name for my tools, but we'll hire her one day for that. But right now, we put the resources towards the community and we come up with these terrible names. Anyway. It does work. So the protocol is intended to meaningfully involve folks from underrepresented groups who are at high risk for specific health problems and getting their voice into how the research strategy, not just in the project or in helping share the findings of a project, but in what questions get asked, what questions get funded, how the strategy for research. That had been sort of the glass ceiling, if you will, for partnered research. And it was incredibly effective, and it was a catalyst for the TBI research agenda. We took the protocol on the road, and we worked with diverse groups of women across the counties. We also worked with fathers, and we worked with frontline clinicians. It was really magic to see these groups come together and generate research questions that really mattered to the communities, and then to prioritize them, and how they engaged in that process was really incredible. We then took the community priorities and created a research agenda and then partnered with them to award the grants and conduct the research. So they were there every step of the way throughout the whole of the process. And if you have 3 minutes to spare and want to be inspired, please take a photo or a snapshot of this QR code, or just look up online the PTBI research strategy. And watch this 3-minute video. It comes alive in terms of how the process really works. It really was the gift that keeps on giving. Not only was our research more successful, there it goes right now. I didn't trust the technology or my use of it to be able to play it for you, so you're going to have to watch it on your own. But it also provided the community quite a lot of motivation and support for their own further education, getting jobs in healthcare and research teams. Hope Williams, pictured here, really changed careers and became active in UC's PTBI work, as did many others. And they've gone on to do other projects, and really, it was quite transformative as a process. And so, the PTBI continues this great community-partnered work to this day. Now, some of you may think, okay, well, that was a well-funded project. It probably was a unique situation. It probably doesn't scale. Well, I'd like to share a few other examples with you to show you that, yes, it helps to have resources, but we can't wait for that to be done. And we can do it a whole lot of other different creative ways. So our next project I just want to share with you is one that I did with my colleague, Dr. Emily von Shaven, who's a UCSF rheumatologist. And we partnered with young people with chronic illness and their caregivers and their community support organizations to learn about their research priorities. And many of the young people we engaged with in these focus groups had never met another young person with a chronic illness. They thought they were alone in the world with their unique condition. It was really transformative for them to meet other people and build community through this research process. And again, that work has continued on. And beyond our wildest imagination, what came out of this journey of just starting to ask them what was important to them and what questions should we be asking in research, what were their priorities, that led to a community partnered work that turned into a completely new health service, designed from scratch with young people and their families. Now, it didn't happen overnight. It took several years and a lot of co-design work. And it started first as a virtual service, and now, actually, I think later this year, it's going to be a physical space at Mission Bay for young people and their families to really get all of these amazing wellness services, regardless of what kind of chronic illness they have. So it's across all different disease conditions. And again, totally co-designed. We never would have imagined, that our work with research would lead to that, but that's what can happen with partnered research. And the young people and their families also co-designed research studies to pursue the unanswered questions that mattered most to them, and that those questions that hadn't even been on the radar of the academic researchers. And so these are some of the research questions that we're pursuing now, and there's a study ongoing recruiting right as we speak. And so the funding for all this work, up to but not including the physical center, that did take some additional resource, but the funding for the research and the process of partnership, that just happened was very, very modest funding. And that's not to say that more funding isn't needed, but I just want to make the point that it shouldn't stop us, that we can really just do that. And sometimes the funding comes after you've shown that the disruption of the status quo can take us to a better place. We just have to do it. And so the local efforts that finally got us these local efforts got us the attention of the national funders, first with the PCORI, the Patient Care Outcomes Research Institute, and then even NIH started to recognize and acknowledge the contributions that community partners and families were making to health science. And so our next project was going national with the neonatal seizure registry. And this is a project with collaborators, pediatric neurologist Dr. Hannah Glass from UCSF and Dr. Renee Schellhaus from St. Louis University. They established a 9-academic center to study neonatal seizure, and they asked me to set up the parent partner network, recruiting parents from each of the sites. Now, our parent advisors have children who have all had neonatal seizures. Some of them are doing really well right now. Some of them have gone on to have epilepsy and other major conditions. And one of the problems is we don't know, which children are going to do well and which are going to go on to have a lot of other problems. And so we set up this network and we started looking at the impact, the children's development, but also the impact on the families and the children themselves. Our group, which you'll see here, has been meeting monthly. Let's see if I can get this to come up. There we go. We meet monthly by video. We've been meeting since 2016. And the group has informed many of our research studies. Here's a list of some of the current and recently completed studies, many of them funded by NIH, a lot of basic science. And this dedicated group of families, some rotate off, some come on new, again, has been going since 2016, and we've never met in person, ever. It's just an incredible group. And yet we've done so many incredible things and really helped advance the science. We co-publish with the parents, so you'll see circled in red some of the parent co-authors, and they meet all of the ICJME criteria for authorship, and that's just a sampling of some of our papers. But they also then go on to do amazing work with infographics for families and for clinicians, so that really helping get the research into practice, which we all know is a huge barrier. And many of them lead national organizations or other parent support groups, so they help, again, cascade out the word and get the results into practice. So it's been a wonderful partnership. And so then the question comes next, as we've gone national, what happens when we go international? And this is you get some, when you go international, you get something maybe like the Learning from Family study, which we're in the midst of right now. It's a collaboration with the Ronald McDonald House Charities, which is an international federated organization that provides support services, housing and support services for families of hospitalized children in 62 countries around the world. And by partnering with Ronald McDonald House Charities, it offered us to understand the strengths and needs of families of hospitalized children at scale and to draw attention to the worldwide challenges that families face when their children have a health crisis. And by doing this, we can provide strong data and influence policy and practice. So we brought together, so how do we do this? We do the same process. We brought together virtually families and service providers to co-create the research, make sure we had the right questions that we were asking, co-create the surveys, figure out the research process, and figure out how it would work across all of these diverse geographies and language. And I know I'm very honored that many of my team are here who have slogged through this and figured this out, how to get this to make it work. But we can all test that it actually did happen. And so last month we closed recruitment. We have 3,400 families that have participated in the first survey, and we're continuing to follow them longitudinally to see how their lives have been impacted by their child's hospitalization and what we can do to support them. And there'll be lots of exciting results to come in the coming months and hopefully years as well. But what we can say right now about this work is that there is desire and capacity for family and community partnered research worldwide. It's a worldwide phenomena, and so we really should take this work globally. And we just need to put the effort to work out the logistic and the payoffs in terms of, again, the empowerment that you see in patients and families, the bringing together of community, the creative thinking about new resources that can come. It happens on a global scale too, not just locally. And so my final example I want to share with you just brings us back to California, where we conducted and co-designed research on diversifying the midwifery workforce and removing obstacles to midwifery access and reproductive health care for communities who are experiencing healthcare inequities and high rates of maternal mortality and morbidity. And this work is designed, again, to directly influence practice and policy. The two projects remind me to highlight the important role of learners in this work, and all of the studies I've talked about, deeply involve learners, not just in helping to collect the data and to get a little experience, but to really be partners in the research, be co-authors, and really learn to do research differently so we don't perpetuate the same old status quo of a hierarchical and paternalistic system. And so the actions, postdoctoral scholars who have been part of those two studies that I just showed you is really just the pinnacle of the trajectory from research to practice. And you'll see Bethany Golden, who's sitting in the audience and circled here on the virtual signing by Governor Newsom of AB 1918, where the work that our administrative director, Nikki Lanshaw, and all of the actions team, again, some of them who are here, helped to support. And with this research and with this advocacy around policy, we now have the California Reproductive Healthcare Services Healthcare Service Corps, which is a multidisciplinary group that is going to really accelerate training for not only learners in multiple disciplines, but also to upskill practitioners so that we can better meet the reproductive health care needs during this time of crisis in the U.S. And so you'll see, again, over the coming years, some really exciting work coming out of the Reproductive Health Care Service Corps. And our actions team is going to be there with our data, trying to help measure the impact. So I hope that hearing about these different ways that we can partner with patients, families, and communities, and how crucial that is, but still how underutilized it is, as an approach has inspired you in some small way. For those of you in clinical practice, I hope that you will go back and look with new eyes at the healthcare system and see where you can be a better ally and advocate for families, and knowing how hard it is in the system that's not designed for them, and keep trying to remove those barriers and keep trying to redesign those systems to make it work for the people that it's supposed to serve, at the bedside and all the way to the boardroom. I guarantee you, and we have plenty of data to show you, that the patient outcomes will be better, your job satisfaction will be better, and the healthcare institutions will actually function more effectively and efficiently if we really double down on this. And for those of you in research, well, I hope my remarks are a call to action to you in your research, to go back and think about how you can do more and do better to, again, bring patients, families, and communities in the work that you do. It's a constant journey, and we need to continuously learn how to do it better. That I will be striving alongside you to do that. I like this, this little graphic because it's very ambiguous. You know, the little cranes could be dismantling trust, or they could be building trust. And I think it's a wake-up call to us, because our research can't just be driven by our own intellectual curiosity and our academic institutional priorities, or our trying to build our CVs, because we're at a point of crisis, and trust in science is at an all-time low. This is from the Edelman Trust Barometer, fascinating survey, comes out every year. 74% of people surveyed say they trust scientists and peers equally for truth about innovations. So, and that's a very big dip in the trust in science from past years and decades. And so we've got work to do. And I propose to you that by bringing in patients, families, and communities as partners in the research, we can actually build back trust in science, not dismantle it, but build it back, and that really would be the way forward. And for those of you who are not in research and not in clinical practice, but you are a patient yourself, you have a patient in your family, or care for somebody who has a health condition, I think that maybe covers about everybody in the room and online, all of us. Think about what you might do to get it more involved in your own healthcare advocacy, that of your family, and to get involved in research and get the questions that you want answered. You have a very powerful voice. Maybe you haven't realized it, maybe there hasn't been the opportunity, but it really is, your voice really, really matters in that role. And even those of you who have a professional role, when you're on the patient side of thing, you know that that's very different. But there are very important and tangible benefits if you can make that effort. This is a quote from one of our parent partners. It's been 7 years since I came back to the same NICU where my baby was born. I came back because I was grateful for the care team, but I soon realized that besides being grateful, I could advocate and be a voice for the families. And so, paying it forward, helping another family is very transformative and can really make a difference. And your involvement, especially where health conditions are disproportionately affecting your communities or communities around you, can also be very transformative and, again, help build community capacity and agency and contribute to addressing health equity and getting rid of the inequities. Your voice matters, and you have a lot more power than you think. So please share your stories and make your voices heard. So receiving this award has brought a much appreciated opportunity for me to reflect on my career as a nurse scientist. And back when I was a teenager, joking around with my friend Chris about a career in nursing, I could never have imagined that my nursing career would lead me to this work. and would lead me to be able to work with so many amazing clinicians, other educators, researchers, brilliant students, and collaborators. Never would have imagined it. And it's just been a very incredible and huge privilege. And I hope I've lived up in some small way to the nursing social contract that I signed up for, and in some meaningful ways have paid it forward to others, and paid forward the mentorship that I've received. So that brings us full circle back to where we started with gratitude. And I want to thank you again to my nominators, to the research committee, to my dear and brilliant friend and colleagues, Susan, and to all of you for your kind attention and interest. Let's go out and enjoy some refreshments, and don't forget to thank a nurse. Thank you. Linda, wait.
Come back. So one last thing. We just want to say first, thank you. That was just an amazing talk. You've had an amazing legacy, and it's so neat to hear you share your love for nursing and for your colleagues and for all of the people that you've impacted in your life. And we're honored to have you in the faculty of the School of Nursing, so thank you. And I wanted to give Linda, I'm going to give her a medallion, and it is very impressive. So first I'm going to just talk with the mic here, and then we can stand in the middle. But it is quite heavy and beautiful, and it says University of California, San Francisco. And in the back, it says Linda Franck and the 43rd Helen Nahm Research Lecture. So I want to hand this to you in the middle of the stage. And I want to, thank you. And I want to invite all of you to please join Linda, colleagues, and friends outside for a wonderful reception. Thank you for coming today.